All right, good afternoon, everyone. My name is Ahmad Brahmi. I'm with the Fresno County Department of Behavioral Health, and you are hopefully tuned in for our virtual community planning process related to the Behavioral Health Services Act. Those of you that are not able to watch this live, we will have this available on, I believe, our YouTube, so you may be watching it at a later time, but the information will still be the same. There'll be opportunities for you to, if you're not on the live one, to be able to ask questions and still submit questions and comments as well. This is our Behavioral Services Act planning process. This is a little different than what we historically have done with our Mental Health Services Act. Different process and different requirements, so we'll go into those. Just as a heads up for everyone that is participating, or if you were going to be viewing this in the future, you will see the information on the screens and the slides. We will not be reading everything that's on the screens or the slides, but we will be discussing some of the specifics on items that are on the slides. With that said, I need to go to the next slide. So our mission, vision, and goals here at the Fresno County Department of Behavioral Health. Vision, health and well-being for our community. Simple, to the point. Our mission, the Department of Behavioral Health, in partnership with our diverse community, is dedicated to providing quality, culturally responsive behavioral services to promote wellness, recovery, and resiliency for individuals and the families in our community. And our goal, which we call our quadruple aim, you see on the screen: deliver quality care, maximize resources while being efficient, provide an excellent care experience, and promote workforce well-being. What we're going to be covering today is just an overview of the Behavioral Services Act, what is the integrated plan and how we've been developing that, some of the timelines related to that, and have some of the key changes and also opportunity for you to post some questions or provide some feedback. So you'll see on here, like I said, what are the content, what is the County Behavioral Health Department? For those of you that are new to this process, a quick overview of what is Proposition 1, which is what is created the Behavioral Services Act. The requirements, because those are really important to understand the requirements of BHSA and how that dictates the planning and then how it dictates the actions and decisions that are made, next steps, timelines, and the changes. So for those of you guys that don't know, the Department of Behavioral Health is a local entity. We are basically a subdivision of the state, and so we're contracted with the state to provide the behavioral health services and substance use services for residents in Fresno County who are Medi-Cal eligible or uninsured and who have a severe mental illness. So we do not provide services for everybody in the county, but we are tasked by the state to focus on a specific population for care. You'll see some additional information there on the slide, which, like I said, I'm not going to dive too much into. But Fresno County is the plan for the mental health plan for the county. We're a hybrid in that we're the plan in terms of we contract for a lot of the services and coordinate care, but we also provide direct services where maybe an insurance company would not. So that is kind of the difference between one of the main differences between the county behavioral health departments and managed care or commercial insurance providers. All right, now we're going to get into the meat and potatoes of it. What is Prop 1? If you've not heard what Proposition 1, it was a law that was passed by California voters about 2 years ago. It was Prop 1 on the ballot. It was a special election. It did narrowly pass. If I remember, I can't remember if it was exactly 50.6 or 50.4. All it needed was 50.1 to pass. It was a simple majority and it passed. It was basically Prop 1 was made up of two packages, as you see there, the legislation. One, which was to try to, what the state call, update and modernize the Mental Health Services Act by calling it the Behavioral Services Act, providing some different priority prioritization and basically allocating how the funding would be used. The other part of Prop 1 was a bond measure, which is on there, which was to be able to fund more treatment, and create housing and some of those supports for individuals in the state. Prop 1, the bond version of it, or portion of it, shall I say, you see under BCHIP, as we call it for short, is $6.3 billion. It is a competitive, there are different rounds of it, so it's not, the money's not released all at one time, but they are released in different rounds. They are competitive, so it's not divvied up to where all 58 counties get an amount or region. It's basically you submit proposals when they have openings or when they're seeking proposals, and you put forth your proposal and the amount. And if you're awarded, then great. And if not, then you have to do the second one. You're not required to apply for it. But in Fresno County, we have applied for the BCHIP funds to be able to build some more infrastructure within the county. Going into the Behavioral Services Act overview. So one of the main things that BHSA does is it changes the project, that changes the funding source from what was called the Mental Health Services Act to the Behavioral Services Act. It does recategorize the populations. It does recategorize some of the funding. It is a lot more prescriptive than MHSA was. MHSA, when it first came out, was kind of presented to us as a way of closing the gap in our system and really addressing the shortcomings that the system had. So things like prevention, linkage, stigma reduction, education, a lot of those things. And then with the Mental Health Services Act, it wasn't until I want to say about 10 years into it where we started getting more regulation, more reporting requirements, things of that sort. With the BHSA, it is a lot more prescriptive, is a lot more structured from the beginning to help guide the process. Some of the main changes is that you'll see on the slide, it does increase the state's allocation from 5% to 10%. That's off the top. So of the total money that goes to counties, they take 5% and now 10% off the top, and then the rest gets distributed by counties. And there's a formula they use based on size, populations, eligible folks, a lot of different variables they have that go into it. So you'll see a couple of key things in there. The thing that I think is really important for people to understand when we're talking about BHSA is that there was this misnomer or this perception that BHSA was going to be new money. It's not new money. It basically took the money that was utilized under MHSA and reclassified or categorized what the money would be used for. So before, which I'll get into some slides later on, you'll see the breakdown of the things that we focused on, like prevention, intervention, capital facilities and technology, workforce development, et cetera. Those were the priority uses for the funds. Under the BHSA, it shifts it to focusing on full service partnerships, things like early intervention and housing. So again, it's not new money, and I'll show you guys on a pie chart later on, but it basically reclassified or reallocated how the funds were done. It does not change the funding source, so it is still based on the same millionaire's tax. So the millionaire's tax that funds MHSA is the same one that funds BHSA, which is an annual 1% tax on incomes over $1 million. So if you made $1 million this year, you would then have a 1% tax on that $1 million. But if next year you made $500,000, you would not get taxed on that. You would not get a 1% tax on that income that's under $1 million. So it really relies on millionaires to drive the funding. And because of that, because it's tax-based, we use the term volatile because it does depend on if you have people who are made $1 million one year, but not the next year, it does impact it. If there's a recession and the economy downturns and, there's not as many people making $1 million a year, that will have an impact. If for some reason people leave the state and they're not in California, that has an impact. So it's not a tax on businesses, things like that, but individual incomes, which again, it has to be each year. So that's one of the significant things that we've always kept track of with Mental Health Services Act, and we'll continue with BHSA because we do need to make sure that our programs and services are sustainable and that they can brace for changes in the funding source. A couple of new requirements that you'll see on the slide. We do have new reporting requirements that does increase a lot of administrative function for us. It does create the integration for mental health and substance use, which is great. It does have some mandated or mandatory services that have to be included with BHSA now. So clarifications, just real quickly. The eligible population is fairly close under MHSA because we also have prevention, and sometimes your population prevention or community prevention is everybody in the community. It was broader. BHSA has a more specific population because it is focused on treatment. So it is focused on individuals who are Medi-Cal eligible or uninsured, who have a serious mental illness or for children, a severe emotional disturbance and or a substance use challenge. The population still remain largely the same. Children and youth are basically ages 0 to 25, and adults are ages 26 and older, but we all obviously have like transition age youth, which are in the like 15 to 25. We have young adults who are 18 to 25 to 30. So this is just kind of the way that they broke out the priority populations, but is not limited to. All eligible persons must receive that are seeking services need to be able to meet the criteria for specialty mental health services, and that's the key. We've moved away from prevention, we've moved away from doing education and training, things like that, and it is really focused on providing treatment for those with the greatest need. Some of the other things in there, these aren't drastic changes from MHSA to BHSA, because under MHSA, we did focus on similar populations, individuals that were experiencing homelessness. Where this changes up for both children and adult, it does expand it to chronically homeless as well as risk of homelessness. So it does allow us to try to support and assist more people. Before it was, for youth or adults that were involved with the justice system, this kind of expands it for involved with or at risk of. Some of the things that are a little bit new is for individuals re-entering the community from either for juveniles, juvenile correctional facility, or for adults from some type of a justice setting, which was not something that they had before. So that part is new. But as far as the other things, those are pretty similar. Reducing the hospitalizations, reducing risk of conservatorships is newer. So there's some things that are new, but overall it's building on a lot of the work we had before. We also are going to work on trying to identify, like I said, additional at-risk populations. So a lot of the work is to get out into the community and field and identify people who have those needs that maybe have not been diagnosed, have not been connected yet with services, folks that are at risk, and to try to reduce those occurrences. So here is that PowerPoint slide I talked to you about with the pie charts. So the one on the left, if you see, is what MHSA funding had been. So more than half, you see the two orangish kind of areas combined. That was the CSS dollars, community service and support. Half of that was used for full service partnership. The other half was used for a lot of other programs that were for individuals with a severe mental illness. So some of those did housing support. Some of those did things like collaborative courts. So there was a lot of things that were done under that. And if you see that kind of stripe pie slice of the pie, that was the state admin. You see that bright green, that was our innovation projects. And then our prevention and early intervention were those blue areas. If you look at the slide or the pie chart to the right, you see it looks a lot different, a lot more slices in there. So that light orange color is the full service partnership. And if you compare it to that CSS FSP on the left-hand side, it's almost the same. So that part didn't change. If you see an area that's new, is that purple, those purple areas. So that housing is new. So it's not that they added more money. It's that the money that was used for some of the other things has now been shifted to the purple. So the purple's housing, half of it is focused on chronically homeless, and the others are housing supports. You'll see those small slices at the top. The state allocation has increased. So it went from 5% to where they have a 3% admin, 3% for statewide workforce initiative, and 4% for statewide prevention activities, which I'll get to a little bit more about that change in prevention. And then you'll see there is on the right-hand side that BHSS. That is, half of that is going to be used for early intervention, which we're going to dive into, and the other half is used for everything else. Now, if you look at the other slices, there was a lot more room, it looked like, for things that were beyond just full service partnership and housing that now have to be squeezed into that light blue slice. And so that is something that is really, how would I say, being key in terms of some of the decisions that have been made, how the planning has been made, because it's what can we support and what aligns with funding resources. So we're going to dive into the housing bucket first. So remember, they're under BHSA. There's three main buckets. Housing is one of them. It's 30% of the total bucket that we get. And so you'll see some of the things in there that eligible housing interventions, that these are basically the ways we can use housing dollars. It's to provide rental and operating subsidies for persons that we serve. When I say we, I mean our system of care. That includes our contractors, not just the department itself. Some of the other housing supports can be outreach with, for example, property owners and landlords to try to get them to, if they have spaces, to rent persons we're serving. Mitigation funds is kind of like increasing the deposits, things like that, that would allow them to incentivize them to rent or lease to ensure the property is taken care of. I mentioned before, half the housing funds do need to target chronically homeless individuals with focus on encampments. I know there was an executive order in Sacramento by the governor, kind of, I don't know the exact word I would use, but banning encampments. But the intent is still the same, is to find individuals that are not treated, that are not in shelters, that are not housed, that are displaced, and really try to help get them into care. Counties can use up to 25% for capital projects. There is a caveat for that. That 25% has to be used, or the project has to be completed in 3 years. So you've got from start of the construction or renovation to where people can move in, you've got 3 years. The state did that on purpose because they're really focused on trying to get individuals off the street and into homes. So they don't want projects taking years and years to build. They're looking for the quickest, fastest way we can help people transition from being in the street or at risk of homelessness to being housed. So that's kind of the reason behind that. And also that 25% is to support counties that may need to invest in that, because we know one of our biggest challenges with housing in a lot of parts of the state, and at least here in Fresno County, is housing inventory. So there's just not enough affordable housing. So this also allows an opportunity to try to, if need be, develop and build some additional housing settings. You see some of the stuff, master leasing, which we've had, things of that sort. The key thing with the housing with BHSA, it is really looking at trying to move people to permanency. So we do have what they call interim housing, which are short-term up to 12 months to help people transition to more permanent housing, and so that folks are more stable. And that is one of the long-term goals of the BHSA, is that permanent housing. So we've kind of touched on some of these things, but in the past, if you've heard of it, so before the FSP programs, or the programs, primarily the FSP programs, full service partnership programs, provided the housing supports for the people they were serving. So if you were in an FSP program, unhoused, needed housing support, they would do that. Under BHSA, they separate the housing from the FSP, and that's actually a good thing. So I know people might hear that and be like, oh my goodness, like, no, that's a good thing, because the problem before was your housing was connected to your level of care, your program. So if you were at a really high level of care in an FSP, you had housing. But what if you stabilize and you've been in an FSP for a year or two and you're wanting to step down, or you're wanting to go to school, or you're wanting to work? Well, you are at risk of losing your housing then, because it was tied with you being in that FSP program. And then vice versa. It really put our providers and FSP providers in an odd place, because you may have a person that's ready to move down, but if you move them down, you've got to find another housing for them, or you risk making them homeless. So that kind of defeats, you did all this work only to have the person be homeless. So this takes that problem out of the FSP focuses on the care. So if the person needs more, you give them more care. If they're ready to step down, you can help them step down. And a person's housing is not going to be based on their severity, but it's going to be based on what their housing needs, something completely as a standalone. And one of the other things is that we're able to also use some of the housing funds to support folks that are SUD recipients, people receiving services for substance use disorder. And before, that was kind of separated. The housing money has to be used for housing, though. So it cannot be used for treatment. So when I say for housing, it can pay for the rent, as we talked about in the previous slide. It can pay for leases. It can pay for things of that sort, deposits. What it can't pay for is any treatment that occurs on the site. It can't pay for any of the case management that you get in maybe a supportive housing, or the services that are provided on site. So it's really focused on the housing. The other thing that is new is the state has been able to get a new Medi-Cal benefit for individuals that's called transitional rent. It is a new benefit, and so people can get up to 6 months of rent paid for through the managed care plan, through Medi-Cal, basically. So what we're required to do is coordinate with those providers to make sure any individual that's going to receive housing through Behavioral Services Act has used or has exhausted those, or they're not eligible for it. So that's a way that they can pay for 6 months of transitional rent BHSA can be used to pay for an additional 6 months, or it can be used to pay to help transition someone to more permanent setting. But that is something that is new. It's a new benefit. So that's additional ways that we can support our unhoused individuals in the community. And we are required to coordinate to try to make sure we use that money first before we use the MHSA. So that's, again, another positive that is come about in this process. Our big focus is going to be how do we coordinate those. So we'll get into some of the things in a minute, but looking at possibly things like a flex pool to where we have an independent third provider that basically leases and does agreements with various properties and helps coordinate and get the folks we serve the care through the housing. So the county wouldn't be the one trying to place people and pay the rent. Not that we don't have the money, but our processes are longer. You'll need multiple signatures, multiple forms, multiple times that steps it's got to go through to ensure that everything is okay. This one, we would be able to contract with a provider who would have the money, and they would be paying the rent and coordinating the housing for individuals. So this is something that should help us increase access to housing, more rapid housing than we've had maybe historically. All right, this is the second big bucket of our BHSA, which is the full service partnerships. So full service partnerships used to be the highest level of care we had in our system, but now full service partnership is going to be kind of several levels of care. So we are now required under BHSA to provide evidence-based practices, and a lot of these are under the full service partnership category, which include assertive community-based treatment and forensic assertive community-based treatment. So let me start with those two first. Years ago, when California started the Mental Health Services Act, one of the things they wanted to do was the full service partnerships. Well, the full service partnerships were based on the ACT model, the assertive field-based, but they didn't call it ACT. They kind of did ACT-ish. So it was kind of like ACT, but it wasn't exactly like ACT. It did not have those fidelity requirements. And so we called it FSPs. But now the state has revisited that, and they're saying, like, no, we want to have at least an ACT or a FACT in every county. So we have the people needing the highest level of care outside of being in a hospital or in an inpatient setting are going to be able to get that. And we want to do it to fidelity to make sure like we're getting the results that it's supposed to do. So that's something new right there. We do have to implement an ACT or a FACT to fidelity. We have to implement individual placement supports, IPS, which we have one of those already. The big thing is making sure that we get it up to fidelity. And the other one is going to be a new level that they're calling high fidelity RAP to support our FSPs for our children and youth. So those are three things that are, or four things that are new. They're evidence-based practices. We do have to meet fidelity to those. So this is what that means is the state is going to is providing already technical assistance and training to help counties and their providers start working towards that fidelity. At about 1.5 years into our BHSA plan, they're going to start doing fidelity checks to kind of see like how close are you to being there? Do you have the training? Do you have all the systems? What do you need to get in place? Because the goal is to have all counties be to fidelity by July 1, 2029. So 3 years, we need to have all of these to fidelity. The catch is if we don't get those to fidelity, then you can't use BHSA funds to fund those programs, and you can't use your Medi-Cal. You can't build Medi-Cal. So kind of, they really, how's the word I'm looking for? They're really leaning on us to make sure we get these things up and running in a reasonable time. So we're confident these will happen in 3 years. Like I said, we're already working with a number of our providers and getting the technical assistance and putting systems in place. So this will actually be a good thing because we'll have models that'll provide what is proven, if you do them right, proven to be effective. One of the other things that is different with full service partnerships than the past is now full service partnerships can also provide and fund substance use services, specifically medication assisted treatment. So MAT is what we call it for short, often to treat opioid addictions. But in the past, that was not something that was an option. That is something that we now have. Full service partnerships have to all now be co-occurring capable. So what we mean by co-occurring capable is they have to be able to serve both a person that has a mental health issue and a substance use. A lot of times in the mental health field, if someone had both a mental health and substance use, they would treat one and then refer you someplace else for the other. We in Fresno have had a co-occurring FSP provider, so we're a little bit ahead of the game in that regard, but the state is requiring for FSPs to be co-occurring capable for everyone. That could mean you have substance abuse certified staff and counselors as part of your team that are providing service on site. It may be something that you have formal agreements, MOUs with a substance use provider where you are both treating that individual at the same time and you're able to share information and progress and things like that. So that's something that'll be more at the contractual level as we develop those contracts with providers. But it is something new that we now are having that requirement for co-occurring capable and can pay for SUD, because guess what? That actually means we're getting closer to really having an integrated system. Last thing I want to touch on with this one is that there are some additional efforts with doing community-defined practices and early intervention in the later part. They have made that as an option you could do with FSPs, but they don't quite line up yet at this point. CDEPs, as we call them, community-defined practices, are really organic, community-driven. They would need to be developed for an FSP and would probably be unique to each FSP. So as far as I'm aware, and I've been involved with CDEPs for almost 7-8 years, I'm not aware of any that has been scaled up to really do FSPs, but there's opportunities there. So this is our third bucket. We're almost done with our 3 buckets. This is our third bucket of the BHSA, which is behavioral services and support. So this is 35% of the funding, and the funding is really broad. Half the funding, though, has to go to early intervention services, and they specify what type of early intervention, which we're going to get into in a second. The rest of it is to fund all your other services that you've done. That's why, if you remember when I was showing you guys the pie charts, I said that light blue sliver is kind of hard because you have that small blue that's basically doing the work that was a larger slice of the pie. These are the things that you can use BHSS funds to do if you have the funding available. Continue to provide children's and older adult care, outreach and engagement for specialty mental health services. So this is really, I do want to flag this one real quick, because under prevention before, we had a category that was outreach and engagement, but that was more of outreach and engagement to help people learn about what is mental health, what is substance use, what are the resources, what is suicide prevention, where do you go for help, doing some of the stigma reduction, things like that. Under the BHSS, the outreach and engagement for special mental health is really meant to target individuals that have substance use or serious mental illness and try to engage them in care. So it's not as it's not as random as the work that our team maybe had done in the past, where we might be at community fairs, we may be at block parties, we might be at resource fairs. I'm trying to think what are other things we've done, health fairs, etc. Those were really broad and were really effective for what we were doing in terms of community outreach and engagement. This is required to be really specific. So it's going to be more doing the field-based, trying to target those encampments, maybe targeting places that we know have higher frequency or use of substance use, places where maybe more individuals are displaced, more public spaces, maybe like parks or things like that, that can allow you to engage individuals that would really benefit from services. Continue to fund crisis services. You can, in addition to what the state is doing, workforce education and training. However, that needs to be different than what the state is doing, because the state, like if you guys remember off the top, I showed you that some additional slices to the pie are doing some of that. So counties can do that, but it needs to again be different, and it needs to have specific focus of how do you have your workforce match your populations, but also how do you retain your workforce? How do you recruit for your workforce? So it's less training, but really how do you sustain your workforce? Capital facilities, so that is funding opportunities to continue, as we've had in the past, develop and create things like PUF and crisis stabilization units and other facilities to provide treatment. Technology needs, if you need them, could be utilized to fund electronic health records, software and things that allow you to provide better tracking and outcomes, a lot of options. You still can do innovation projects. So you can still do innovation projects if you want with these funds. I'll get into in a second. We are not going to be doing any innovation projects in this new 3-year plan, because the money that we would have to use, we're actually trying to really focus on treatment and things that are mandated. So we're not able to really do things that, I don't want to say are luxury, but that you would have more opportunity to explore at this point, because we have limited funds and we need to make sure we're getting the most out of it. We got to focus on the things that that are required. So we're going to jump to the next slide real quick. So as I said, of that BHSS pot that we were just on this slide, 51% has to be dedicated to early intervention. Now, one of the things with that is the states is prescriptive with BHSA where they were not with MHSA. And so you have to implement a coordinated specialty care for first episode psychosis program. That is an evidence-based model that has had really great results when it's done to fidelity. So this is another project that we're going to implement, and we're also going to have to get it to fidelity in the next 3 years. This project is probably going to be targeting to start for transition age youth, young people, late teens, young adults, where oftentimes we see the first onsets of a severe mental illness, with the goal of getting folks engaged, getting them the support they need, not letting them fall through the crack, and so that we can stabilize and they can continue to live long, productive lives, versus a lot of times if people fall through the cracks, it's years later that we really get them the help they need. And by then they've had hospitalizations, they may have had justice contact, they may have had, more challenges with substance use, homelessness. So this is a way to really prevent a lot of that suffering in the long term. Of the funding that we put up for early intervention, see, this is where it gets sometimes tricky. I said of the behavioral health services and support, half has to go, 51%, or half has to go to early intervention. Of that, half of that early intervention has to go to children and youth, the rest for adults or older adults. And so those have some requirements. Like I said, that especially care for first episode psychosis, that's one of our priorities with that. And there's a couple of the projects and programs that we will be able to retain under early intervention. But it does change some of our focus a little bit. There's no funding for prevention at the local level. The state is keeping 4% off the top for prevention, and that's a lot. When you say 4%, it's not a lot. 4% off of the total statewide for MHSA each year is a lot of money. And so they're going to be working with the California Department of Public Health to try to do those. Now, it's not clear if it's going to be all done by the California Department of Public Health, if they're going to share some of that with local public health departments, if they're going to do RFPs or contract for direct services, but they are going to do some statewide prevention activities, and we're not clear on what they may do locally yet. So that is something that we do not have new information on as of today. BHSA has established a list of evidence-based and community-defined practices. It's a list that they will continue to update. They haven't finalized it yet, but that also is something that counties can use. So like if you are looking at, hey, what are some additional early intervention projects I need, or community-defined projects you need, you could utilize this list to find and approve ones that would be supported in your plan. Again, that's all based on if you have the funding available to do those. So the next thing we're going to talk about, and I'm going to get into more later on, but the next thing we're going to talk about is our statewide population goals, or behavioral health transformation goals, or BHT goals for short. So as part of the statewide effort of behavioral health transformation, the state launched a number of initiatives. One was BH Connect. Another one is the BHSA, Behavioral Services Act. There is the Children and Youth Behavioral Health, CYBH, the Children and Youth Behavioral Health Initiative, and I'm probably missing one other one in there, as efforts to really improve the overall wellness of Californians. So if you see on the slide, it says there were 14 goals that were looked on improving the wellness of Californians. You'll see that table on the right has what those 14 goals are. There's a number of them that are seeking on ways that California can improve through efforts at the local level. And then there's ways that they feel we could improve wellness by reducing some of those negative outcomes. So there are these 14 goals that we're going to work on. If you look at them on paper, some of them you look at and go like, well, is that really a behavioral health area? It may not be, but they are focusing on what part behavioral health plays in those ones. So in time, they'll hopefully expand it to additional partners. But right now, it's the behavioral health. Both county and the managed care plans are required to address these behavioral health goals with their efforts. So each program that we have under our behavioral service plan is going to need to be kind of supporting a behavioral health goal. The difference with MHSA and BHSA is like BHSA is now an umbrella for all of our services. So before MHSA, if you guys remember, was just for the MHSA funded. We had a separate plan for substance use, separate plan for everything else. The BHSA plan is a plan for all of it. And so as you have all of them in there, all your programs need to have a outcome. So one outcome is like, okay, how does your program support overall wellness? Will you attach it to one of these goals? So here's the part. Of those 14 goals, counties are required to do 7. The state prescribes 6 of those, which you have right here. Increasing access to care, reducing homelessness, reducing institutionalization. And what they mean by institutionalization are people that are in hospitals, psychiatric hospitals, locked facilities, things like that, reducing those. Reducing justice involvement, that could be from incarceration to just having justice involvement. Removal of children from the home, untreated behavioral health, reducing untreated behavioral health conditions. So those are 6 of the 14 that they're requiring everybody to do. Then they said you as a county get to pick your 7th goal. Your goal has to be tied to data and outcomes, though. So it's got to be like, how are you performing? What data are you using to show that and where you can make an improvement? So to our credit in Fresno, over the past 7-8 years, working collaboratively with so many different partners and having the collaborative coalition from school and law enforcement and first responders and educators and community-based organizations and public health and hospitals and the list goes on and on. We've had a significant impact in reducing deaths by suicide in our county. It's not where we want it to be. Our goal is 0 suicides. We do not want anyone losing their life in Fresno County. Our goal is 0 suicides. However, we haven't got there yet. When this effort started about 8 years ago, it was very high. It was in the triple digits at about 118. Through collaborative efforts and everyone really talking about it and utilizing resources and support, we've been able to reduce those into the double digits, and we've been able to kind of keep seeing improvements. That's great for us. It wasn't great for a BHC goal because it's like we couldn't put reducing suicides as one because the data shows that Fresno's already trending down. So we're already doing good. They're like, no, pick another area. So we looked at overdoses because we've had a lot of overdoses, right, in recent years in the valley and in our community. And so it was like, okay, let's look at that. But when we look at the data, we see that thankfully in Fresno County, the numbers are going down. So there's been a lot of work where there's people talking about and helping educate people about the dangers of opioids and fentanyl, whether it's been billboard campaigns or bus ads or distributing Narcan or ton of different efforts is having an impact because we're seeing those deaths by overdose go down. And as a result, it reduces our option to utilize that as an outcome. So one of the other things was like, do you look at school engagement? We're like, well, that's really broad. It's kind of hard to really figure out how that would work. And one of the things that they wanted to use was the Healthy Kids Survey. But since the pandemic, not all schools have been doing a Healthy Kids Survey on a regular basis. So if we use that, you're not really capturing like all your districts in school. You're kind of getting pieces of it. And it really wouldn't be accurate. So we didn't feel we wanted to tie ourselves to something that we couldn't be accurate and know, well, what are the actuals and are we doing a better job? So the one that we're choosing or at least recommending and presenting to you all today is engagement in work. And that's specifically looking for engagement in work for individuals served by our behavioral health system. So individuals with a substance use, people coming out of hospitals, people in our FSPs are stepping down, folks that are looking to get employment or to school and to transition back to independent living. That's where we wanted to focus on because Fresno, as you all know, unfortunately has a really high unemployment rate. That is a challenge we've had in our area. And so if you're an individual that has substance use histories or mental health histories, it oftentimes is harder to find work. And so when we looked at that data, the data was low and we felt that that was an area we could really improve on. And especially with our full service partnerships, we're going to be utilizing the IPS program, which is basically job prep, job preparation, coordination, possibly placement, but really providing specialized employment services for FSP participants. That means there's a lot of people in our FSP programs that could start making that potentially that transition, and when they're ready, be able to take advantage of that. So we thought that was an effective place that we could put and we could really move the needle and be able to show the state some improvements. And it also goes to helping our individuals. We know that when individuals work, it improves their self-esteem, self-confidence. It helps people get engaged more in their community. It helps people become more sustainable. So there's nothing but positive opportunities that we can, I don't want to say nothing. There's a lot of positive opportunities that are going to come out from being able to set that as a goal. So one of the things I want to jump back to is talking about the integrated plan, like I was just saying a few minutes ago. So before, our MHSA plan was basically how are you going to use the MHSA dollars? The Behavioral Health Services Integrated Plan is what is your plan for your county? Not how you're going to use BHSA dollars. It's what are your plan for your county? And they used the term integrated plan because they wanted us to include things like substance use that historically had been separate, to really be like, hey, it's all one system. We want to address and treat the whole person. So integrated plan is what we're working on. It does require us to report all of our programs in there. We do need to track all our programs. We do need to connect all our programs to one of those 7 goals I talked about. It does require us to track all spending on the program. So any services that the Department of Behavioral spends money on, either internally or through contract, we have to track. There was a question that was asked from someone of, well, does this mean you have to track everything the contractor does? We don't get into the contractor's business. We track whatever we're paying you through the contract. If they have other grants or things, we don't look at that. But if the county has grants, we have to report that. If the county has any other funding that comes in to support behavioral services, those are things that we have to track in here. It is going to be heavy in terms of data, in terms of assessing programs, in terms of evaluating programs, in terms of using data to make decisions and be data informed. So it does, in that regard, it does change and it does increase the workload, but it'll, in the long run, we believe, help improve our overall system of care. For the integrated plan and also for the BHC goals that I mentioned in the previous slide, the state does provide us with the data for that. So we don't say like, oh, okay, for what is one I'm going to go back to? And I don't want to mess up our slides and jump back. But if it was for access to care, we can't go like, oh, well, for access to care, I'm going to say how many people got care in a month. It's set, the state sets that for us. Of like, hey, from contact, you have 7 days. Hey, from this setting, you've got X amount of days. So they set those, and they've done that so that it is standard across the board for all counties. So everyone is working with the same set, and it's easier for them to assess and evaluate. Because if everyone is doing something different, 58 counties and 2 cities that do BHSA plans, that is 60 different ways of doing it. And so they really wanted to get that standardized and uniform, and they want to be able to validate the data. And then what we're going to do is be collecting the data each year, and then the next 3-year cycle, we'll have enough data that we'll have created a benchmark, and it'll start going like, okay, now you need to go up from here. All counties are required to create their BHSA plan through a portal now. So if you guys remember, our plans could be 200-300 pages, 500 pages, depending on if it's an annual update, if it's a new plan, depending on how many exhibits and things that are in there. And this was true up and down the state. And so when the state would try to review plans, when our association would try to review plans and try to help us, when the legislators would try to review plans and say, hey, let's look at who's doing a great job in, I don't know, with FSPs, it was really difficult for them to get that info because you're talking about 60 different plans written differently, different formats. Some people may put their stuff by levels of care. Some people may group all their FSPs together, all their prevention together, you know, by that category. Some people would maybe do them based on like how they design their system. Like, okay, these 4 programs feed into each other, so we're going to feature those as a cluster, and these 6 together. So unless you know how every county did theirs, you are searching all over those documents, hundreds of the pages, trying to find stuff. So the state was like, no more. We're going to create a format. And so it's a portal where we enter. So they have boxes, text boxes. They specifically say what they want you to put in there. They put a limit on how many characters you can have in there, so you cannot go on and on. It's like, I think the most one's like 16,000 characters, which is not a lot. So it's going to be a different process, but it's going to keep it pretty standard. So if you were to go look at counties that have completed their plan so far, I think Contra Costa, hats off to them, and Marin County, another one, hats off to them, who finished their plans. if you go look at their plans, they're formatted and kind of structured the same way. And so when Fresno's come out, it's going to look the same way. And LA's is going to look the same way. It'll have different information in there, but it'll all be in the same order. So we're working, that's how we're going to do the plan. Now, what you don't have to worry about is you do not have to go into the portal. Once we're finished with the plan and we kind of hit the button, it'll consolidate all of it into merge it into a one document that you can read. So it'll probably be a PDF, but you can print it, read it. I just know when you do things like that, where you take a bunch of different pieces in a portal and you squeeze it into paper, it does look funky sometimes. So we have heard from some that it does look, it's not pleasing to the eye, but it'll be in order. The table of contents are set, and then everybody's plan will look the same. So that'll help with a lot of that tracking. It'll help with people being able to know what's in the plan. It'll be able to help with oversight, all of those things. Let me see. One of the things you see on there a couple of times is that acronym BHOATR. BOTAR. It's been pronounced every which way. It stands for Behavioral Health Oversight Accountability. Oh, and we just said this one where we just had the T and I forgot it. Tracking. Thank you. So it's the tracking report. That is going to be both like a financial report of what is all the money that you had come in, what is all the money you've spent, but you're also reporting your outcomes on that of, well, how did your programs do? What impact did they have? Are you guys meeting those goals? Things of that sort. Are you close to fidelity? So it's going to be a really robust report that we have to do. Our only challenge is that we have not seen it yet because the state has not released it. And our plan is due in less than 60 days. So March 30th, all plans are due to the state. And I'll get into that in a second and give you that timeline. But that's kind of challenging for us because we're trying to design programs, develop RFPs, amend contracts. And as you're trying to make sure you're tracking for the right things and reporting for the right things, if you don't know what you're being required to report and track, it kind of makes it a little hard. So more than likely, we're like 99% sure. Once we get our BHSA plan done and submit a 3-year plan, we'll be coming back to you all early next year, early next fiscal year, to be working on an amendment, because by then we'll get a lot more information that we're missing right now, and we'll be able to come in and amend our plan and provide some updates with that. This was a useful kind of tool months ago. I don't know as much now. When BHSA was first coming out, it was a way to kind of help visualize how to integrate behavioral health and mental health. I mean, substance use. So if you see on the top, it was substance use. On the bottom, it was mental health. And before, you would even see these things on the same page. And so now you can kind of see the comparison areas where there's overlap, areas where they're different. You see, like on the gray on the right, the housing intervention. It doesn't have a line between it because it's like that's all one. Housing is all one. It's not housing for substance use, housing for mental health. Housing is all one. So this was really useful, like I said, 6-7 months ago for us when we were doing a lot of the planning. This kind of helped us like where things go, but we've left this in there, but it's not maybe as relevant for some of you guys watching. Integrated plan. So we are not to do the workforce investment because we're not supposed to include those in some of our expenditures, capital infrastructure, quality, and accountability, which goes into really putting in measures. How are we assessing our program? Are we collecting all the information? How do we know the program is working? We're spending all the money. How do we know it's working? Well, what do you want it to do so you know what is working? Well, I want it to do A. Okay, then we need to track these things. So we're doing a lot of those things, but that does not go under this. We're still required to report them in our expenditures, but it's not a set aside for these activities. So that's just one of the things to note. And I didn't cover one thing, but I'm going to probably cover it in a second. So lastly, with the integrated plan part, it is a 3-year plan. It'll take effect July 1, 2026, and it goes through June 30th, 2029. We have to turn our plan in by March 31st to the state. At that point, the state has 30 days to review or approve the plan. So they can review it. If they need to send any changes back, they have 30 days to let you know, hey, you know what, you guys need to fix this, or you need to change this, or hey, your plan is good to go, submit it. If they do not respond by the end of the 30 days, then it's kind of like by not responding, the plan is approved. Thus far, everyone has been getting their plans approved, but I think as you get closer to March 30th and everyone's getting their plans in, they may get a little busier, so we don't know. But we're hoping to have our plan back within 30 days or sooner than really of receiving it. This will go to the county CAO before it goes to the state. The state requires that your county CAO has reviewed it and signed it, more than likely just to know like what are the fiscal and budgetary impacts and some of the changes and things like that that are proposed. Once it's approved by the state, it comes back, we will have public hearing. We will do the 30-day public comment. It'll go through all the normal processes that we're used to, and then it will go to the Fresno County Board of Supervisors for final approval, because they're the ones that have authority for the final approval. And as long as we get it done by June 30th, we are good. So we're working on that. Our timeline looks like we should be okay on that after this week. Or Aaron and some of our other team, Aaron's our program manager over BHSA. If you're not new to this, you're familiar possibly with Aaron. If you're new to this, that's who she is. And our team are going to be for the next 2 months just writing to get the plan into that portal. A lot of the work has been done. We have a lot of the information, a lot of feedback, a lot of those things, but we're going to go ahead and put those pen to paper, shall we say. You'll see some of the things that are going to be in there. We need to be able to talk about right now. We're like what we're doing, a community planning process. What are the goals? What are the demographics of the county? What is our capacity? What is our workforce strategy? Sustainability, all those things are going to go into that plan. Some of the things that we've done so far in preparation, we spent months and months working on this plan. And part of the challenge is from when this was approved to where it's got to be enacted is just, barely over 2 years. And so for the state, it's okay, well, we've got to come up with all these new things. So they've been working really hard to come up with those things and then turn around and try to push it out to us. The challenge is if you don't have some of the information, you really can't do the planning and go to the next step. So it's been slow, and that's why we're working on all these things now. But throughout the past year or so, we've been looking at what are the things that the state has said is going to change. What are the allowable funding? How are they defining housing? How are they defining early intervention? What are we required to have for an FSP? All of those types of questions that we've done to be able to assess and evaluate our programs, like how much do our programs cost? How much do we need for sustainability? What programs are working? What are the things we're going to have to track? What are the things we're going to have to change to track? What is the capacity? Where else does this align with? So a lot of work has been done in that assessing and evaluating all our programs, internal, external, our systems, things of that sort. And then we also are looking at designs and redesigns that are going to help us align our programs and services with BHSA, with the funding, and with the outcome goals. So we are in the planning process. We're going to have this planning process go on for a couple more weeks with opportunities, which I'll present to you guys in a bit, to do some surveys, send comments and feedback, so we can get those in. And at the same time, I do remind folks that this process is a lot more prescriptive than it's been in the past. In the past, we would get folks in a room, maybe do a needs assessment, get ideas on what are the gaps, discuss it, go back, see, okay, is that something that can be done? Now, based on the funding categories are kind of locked in, the services that are required are mandated, there are evidence-based practices that are required that do use up a lot of resources at time and are really strict. Those things have all played a factor in terms of how much we can add versus, where in the past it was a lot more open discussion. It is a lot more prescriptive, is what do we have to do? And once we've done all those, then we look around like what else is left that we might be able to do. This is something that the BHSA changed. So I just wanted to flag this for you guys. They expanded the required stakeholders. Once again, in Fresno County, we were a few steps ahead. Our community stakeholder process, we were already engaging a lot of these stakeholders before it was even required. They did add a couple of new ones in there, so I'm trying to look like disability insurance is a new one. We formally making sure that you have engaged with the managed care plans is new. But in the past, we were working with veteran agencies and organizations. The labor one is new. But healthcare organizations and hospitals, we've done that. Higher educational partners, we've included them, local agencies. I'm gonna jump to another slide that's similar to those. Area on aging, regional centers, represent from the LGBTQ community, people experiencing homelessness. These are all community members that we had historically engaged. So it's not new for us in Fresno. So when they said, oh, you got to do these, we're like, okay, yeah, we've already done that. What we've done this time around is in the past, we may have had a lot more in-person meetings. If you guys remember, I mean, some years we were close to 20 forums over like a month period. We would do them at nights, weekends, days. We would come out to your community. We would do them with partner agencies. We would do stakeholder interviews and a lot of other things to really make sure that we got input and support from the community. Our engagement is we've still sent notices out and we're trying to engage everyone, but we've tried to engage them in a handful of community forums and these virtual opportunities and other ways that people can still submit surveys and feedback and things like that. We didn't do as many of those that we've done in the past in terms of in-person, and there was really two reasons for it. One, this process under the new BHSA is a lot more prescriptive. So you need to be respectful and courteous of people's times. You're asking people to show up on a Thursday night after work. You're asking people to show up on a Saturday, give community input. You want them to really have that robust discussion and input. If it's coming, we're going to do that, and you're going to have that discussion and say, I think we should do this, and I've seen a need for this, and you give us a list of 10, 15 things that you really think the community needs. And we don't disagree. We're like, yes. But we turn and say, I can't do any of those because I have to do these other 10 things first. It kind of erodes some of the trust and relationship with the community, or just not being respectful of people's time. And then the other part with it is we have to, as of right now, which I'll get into a couple slides, have not gotten some final instructions from the state on some of the requirements and programs. So we couldn't do these earlier because we would have came in there and what we told you may then change, a couple of weeks later. So we really try to put it off as long as we could so we could have as much complete information as possible from the state before we did that community forum. But all these stakeholders have been notified and additional ones. And there's, like I said, still going to be opportunity for the next few weeks for people to still be able to voice their opinions, give us their thoughts. And again, we're getting this done by the 31st. We will come in the new fiscal year and be having community forums and a bunch of them to really engage with people. The other thing that I wanted to note is while on here, it shows these focus groups. We've also throughout the, stakeholder groups throughout the year, we've been holding because we knew BHSA is happening and we're gonna have to do this. We've had throughout the year different community forums. We've held different listening sessions. We've done focus groups. We've done surveys. We've done key form interviews. So we've been collecting information for almost, I would say, maybe since August, September. But not on a large scale like this, but we've been collecting info and we're going to keep collecting info after March 30th. We're going to keep collecting info each year because we don't want to do one time. We want to be collecting info throughout the year to really inform what are our needs and opportunities. All right, stakeholder meetings. So I just touched on these. We've done the stakeholder meetings. We've done focus groups, surveys, key informant interviews, and you're still going to have the opportunity to participate. We are looking at keeping the survey, which I'll provide a link to here shortly, open till mid-February, so you get a chance to really give us your 2 cents if you can. If this survey, if I recall, I think it's 6 questions, 5 questions, 6 questions. It should take you no less than a minute. It's pretty much all multiple choice. You're not having to write out open-ended statements. It's really multiple choice. Give us the info. Let us know what stakeholder group you represent, providers, community, etc. That'll help us out as well, and that'll be another way that we can incorporate those. And those are also things that we look at in terms of like, hey, what are people needing info on? Where are people thinking we need to focus our efforts on? And so that as we continue this ongoing process with community planning, that we can be more responsive in the next go around. I'm trying to see anything else in there we want to do. Timeline, we kind of touched on this already. I will leave it up for a second or two for people who didn't get a chance or they want to read it. But if you're watching it later on YouTube, you can just pause it and go back through it. I do wonder, Brian, if we may need to check where I was referencing those 2 BHT goals, the ones with the SP collaborative, because I know the algorithm sometimes will flag certain words.
Possibly. Yeah.
And I think when we talked about opioids and the negative outcome with opioids, that term sometimes I think catches on algorithm. So we just may want to if we need to just
Keep an eye on it.
bleep that part out so we don't, so they don't block the video. So that's our submission. These are references that'll be available. We will make these PowerPoints available soon. If you've been on our listserv, you will get an email with a link. We'll also be looking at putting this up for a short period of time on our BHSA page. But once we kind of do the plan, we'll probably take it down because we're also needing to make sure we don't leave old things up on the website because it does create some other issues. I'm going to do two things real quick before I go through the chain. Well, yeah, I'll come back to it. So one of the things I wanted to highlight for all of our community members watching are the changes that we're going to be seeing within this new BHSA plan. So that means changes from MHSA to BHSA, some of the changes that we're forced to make, some of the things that we're required to add. So key changes, there's mandated services under BHSA. So MHSA had mandated kind of areas, but not specific programs. FSPs, yes, but you did not have to have a mobile crisis response program, right? So under BHSA, there are some mandated services. So one is having an act or fact to fidelity. That's the keys to fidelity. The individual placement and support IPS, which I talked about, to fidelity. Now, this program is going to be supporting all of our FSPs, and there's multiple FSPs. So again, this is where we think it could be a really good way of helping individuals that are ready and are interested in accessing maybe employment support as part of their just their own wellness, but also movement towards independence. High fidelity wrap to fidelity. So this is one I'm going to put an asterisk by, and we're going to talk about it for a few minutes. High fidelity wrap on evidence-based model is what the state is going to be requiring to be implemented for children's and youth. It can be a standalone, or it could be something that's done with your FSPs. High fidelity wrap is primarily a care coordination model. So it does have all of those professionals on there, but they're more coordinating care. They're not providing the direct clinical care that an FSP might be doing. And so that's where in some places it's a standalone that refers to the FSPs. In some places it's under the FSP. You have two teams under FSP. You have your FSP ICM team, and you have, and I need to make sure I explain the ICM. And then you have your high fidelity team. So we're working on those, but the challenge for most counties right now is all we've received is concept papers, draft bins, things like that from the state. So we don't know exactly what it's going to look like, what their ratios are, what the rate for it is going to be. There was a draft information notice that came out a couple weeks ago. A lot of it said, oh, this is going to be addressed in the high fidelity wrap manual. And you're like, okay, cool. And it's like soon to come. And it's like, oh, okay, well, we're in February. We kind of need that information to include it in the plan. Counties that are going to contract for that need that to be able to write RFPs. Counties need that to be able to do their amendments. If it's internal programs in some of those counties, they have to figure out how they're going to redesign it, what it's going to cost. So that has been a big challenge for us. And I think for counties is just, there's so much of this stuff came out that was new, and the timeline to implement is so short that the state's rushing to try to get it done as soon as they can get it to us, but we're getting things in chunks, which kind of slow us down. So high fidelity wrap to fidelity, awesome. We just don't have details on it yet, which is really making it difficult for some of the planning. We have to implement evidence-based practices. So some of the evidence-based practices we're going to require to do, we already talked about, the ACT, FACT, the IPS, the high fidelity wrap, the first episode psychosis. You'll see another one under, like 2 bullets down, that multi-systemic therapy. We also have to do things not for the BHSA, but they're required evidence-based practices. So family functional therapy, parent and child interactive therapy. Those are things that are required. They're not part of the BHSA, but they're also implement things that we have to implement. So first, we're having to implement a lot of evidence-based practices at the same time. Evidence-based practices, as awesome as they are, because they really do work when you do them right, requires a lot of training. It's a lot of new processes. There's a lot of steps that go into it. And so that's just a lot of work that our entire system of care is experiencing right now. I talked about they have to be co-occurring capable. So that's a big plus. So these are new services that when I talked about the mandates on the bullet points above, these are new services that we have to implement. So externally, we've got to get an MST, multi-systemic therapy. This is a little challenging because it's an evidence-based practice. It has a really small caseload. It has a team that has to be dedicated fully to that. And so when you're looking at, you have a small number of cases and the staff that can't do anything else, and that's all they have to focus on, is there going to be the volume they need for that program to be sustainable? And if not, then you have to use more BHSA money to pay for it because we're not able to draw down on the Medi-Cal. One of the things you will see in the policy manual, if you've reviewed it, if not, we can probably tell you where you can find the info, but there's several places in there where in the policy manual, the states emphasizes the need to claim, that counties need to do their due diligence to try to claim for whatever service is possible. And that if you are contracting for services, that you're identifying contractors that can claim and really doing everything to make sure like that they are also claiming where they can. So it really becomes important that all of our programs are sustainable because we're trying to look at what can we sustain with claiming, and then what can we use with BHSA. We cannot just use BHSA and then hope we can kind of claim a little bit. We've got to have claiming be a key component too. And that's why, if you guys recall, the efforts with CalAIM by the state a couple of years ago was to really move in that direction. And now with the state potentially facing like budget shortfalls, those are where you really need to be able to utilize those other revenues. So externally, it'll be multi-systemic therapies. One of the things that's going to be external, it's an evidence-based practice, so it'll be something that might be added to our FSP. So what we call FSPs today, and I should have probably done this like 10 slides ago, and Aaron's gonna like shout at me in a chat with all caps later. What we call FSPs today are going to be called FSP ICMs. In Fresno, that's what we're going to refer to it. FSP ICM, have that hyphen. It's going to be FSP Act, FSP Fact, FSP ICM. The state in that FSP level of care just called what we have right now FSPs ICM, which is intensive case management. But it's kind of tricky because when you say intensive case management, you think case management. But it's still an FSP. It still has to have psychiatric support. It still has to have peer support. It has to have case management. It has to have the therapy. It has to have the groups. It still has to really do that, whatever it takes that FSPs are modeled to do. So to help avoid internal, external confusion, in Fresno, we will use FSP ICM, FSP Act, FSP Fact, things of that sort. So you'll see under the high fidelity wrap, which is an FSP level, the FSP Act. In fact, those are all things that are going to be external. We're working with our providers to have them kind of move in that because as we noted in one of our community plans, we have a provider that's doing FACT. We've never measured it to see if it's like where it is in terms of alignment with fidelity and to fidelity, but we're going to be working on that over the next couple of years. Act, we have a lot of FSPs that do really high level of care, and so that transition and them, it's more of the ratios of their staffing to become a meet Act will be something that will be a transition that could be done. ICM, we have I'm sorry, not the ICM, the IPS. We already have a provider for that. We're working with them on getting to fidelity, so not a lot of changes there. Internally, we are going to be adding some FSP ICM. So our current FSPs are going to exist. The FSP, they're just going to be FSP ICMs. Internally, what we're trying to do is really leverage the staffing and the resources and the opportunities that BHSA does. So what we're going to do is form out of some of our outpatient programs, the FSP ICMs internally. So Fresno County DBH will also have a couple of FSPs moving forward. They will be held to the same exact standard as all of our other FSPs. There's going to be no difference here. It's not like, well, that's a county operated. It's going to be the same one. The difference is going to be some specialty populations. Nothing is finalized, but looking at like for older adult, because we don't have an FSP that focuses on older adult, but DBH does have an older adult team and program, so that might make sense there. There may be some opportunities with some youth. We do have some, but there may be for some additional ones. So we're looking at those. Those have not been finalized. They will be going into the plan, but wanted to flag those for you. The first, the coordinating specialty care for first episode psychosis, that is that new required early intervention evidence-based practice we have to implement. That is something that DBH is going to take on. We're going to work with our Youth Wellness Center and some of the work we've had there to really take that program that has been doing that type of work and really getting it to become that evidence-based model of a first episode psychosis and really, build that up. And so we'll be doing that over the next couple of years. We're going to have new service, a clinical homeless outreach team. So if you guys remember some of the things we're discussing, that we have to focus on chronically homeless and encampments and things of that sort, that's where this is going to come in. So having that clinical homeless outreach team that's going to be going out into the field, trying to find folks that could benefit from services, housing, and behavioral health, which means including substance, and really try to engage the people. And we know it's usually not a one time that you walk up to the person, hey, what are you doing? My name is Maud, you're Mike. Hey, you want help? Doesn't really work that way. It would be great. It might. I mean, if it does, run with it, get that person into care right away. But we know it does take more engagement. People may not know you. They may not trust you. They may have had a bad experience in the past with mental health. And so part of their work is going to be out there building those relationships with people to where when they finally get that person kind of hits that point where they're ready to go, say, hey, are you ready to go? Like, yeah, I'm ready to go to the program. Yeah, I'm ready to check out your program. Or yeah, I'm ready to participate in housing. They can get that person going. It's not going to be like, well, we'll come back next week. That team can engage them in the field, get them done as soon as possible. So some really good positive things coming out of BHSA. Some of the programs that we're having to sunset, and these are partially because they either don't fit specifically under the BHSA plan because they're maybe primary prevention or population prevention, or there just isn't once we fund all the things we have to do, there's just not the opportunity to do those. So none of these are being terminated. These are all contracts that are set to end at the end of this fiscal year. So June 30th, they're set to end. And we've notified those providers that unfortunately we're not going to be able to extend or renew those contracts at this time. So we did have an innovation program, the CRDP Evolution, that funded several community-defined evidence-based practices, CDEPs as we call them. So those ones are going to be ending as far as with DBH. We hope that with the state and their prevention dollars, they'll put those out either through the state office of public health or some other way that would allow the local programs to secure funding for the work that they've done in those population areas. The youth empowerment centers, and this was a program that we had that was really addressing young people on the west side of the county, areas that we know are often, they're geographically isolated. It's not as resourced. These are ones there, but their programs were primarily in prevention. So we're not to do prevention. We don't have the funding for prevention. Supervised overnight stay, not a prevention program, but this one we're transitioning away because we do have the Lodge 2 in its next phase, and it has expanded its capacity and the parameters. And so the folks that would have previously been served by SOS will now be served by the Lodge. So no one is going to have less services. We just, at this point, instead of having two doing similar, we're going with one larger program, which is the Lodge 2, to try to address that need. The culturally based access and navigation services, that's one that's sunsetting. There's a lot more things that are coming up together. So like a lot of the outreach that's going to happen, a lot of the enhanced case management that the MCPs do, a lot more of the care coordination should ensure that people are getting connected to services in a timely manner and doing so in a way that is culturally responsive. And then youth and family advocacy sunsetting. That's sunsetting, but that work or function will come in-house and would be done by our children's team. So changes, to just note, housing is not part of the FSP. So housing will be its own. That's really a big thing that's different. So it allows our FSPs to focus on folks. It allows us to hopefully get people housed and not be limited by the program they're in their housing. So that is a key change. Flex pool, which I touched on very briefly for housing, is something that we are looking at as a county. Flex pool would be a third-party contractor who would be given the funds for leases and rent and things like that for the people that we need a house. And they would then contract with landlords, management companies, apartments, things like that, and be able to pay the rent for individuals. MAP, the multi-agency access point program, not going away. It will continue, but it is going to go through some changes. So it is going to go through some redesign to align more with some of the outcomes and funding for us and for DSS that fund that. trying to make it sure that it aligns with the funding source, with the outcomes, some of those things. And so once that redesign is kind of set up, it'll go out for RFP. And so that'll be a program that'll continue. It just may have some portions of it that look a little different. The wellness center. So right now we have one wellness center known as Blue Sky. We were actually did our first community forum over there. So thank you to Blue Sky for hosting us. Thank you for all the folks that came out. Packed house. Always awesome over there to do that there. The Blue Sky Wellness Center, the Wellness Center is going to stay. We will have a Wellness Center in Fresno County, but it is going to go through a little bit of a redesign, and it'll go through an RFP. And part of the reason these have to go through an RFP is our contracts normally are between 3 to 5 years, and because of a lot of changes with CalAIM and with BHSA and things like that, they've been extended like additional years, and we're kind of reaching the point where we cannot keep extending. We have to have an opportunity for an RFP. So this gives us a chance to do some redesign, looking at how we may be able to incorporate and add some substance use support groups maybe in there, a way for some additional services to be included in there, and then continue those wellness centers just with a little bit of a new design. And then one of the other things that is changes is the Hmong Helping Hand was one of our CRDP evolution projects. It was a CDEP, Community Defined Evidence Practice, with the Fresno Center. Over the past couple of years, as part of that program, some of the TA that they've received, they've been looking at sustainability and transitioning from prevention to maybe be more of an early intervention. So that's a change in that. Hmong Helping Hand will become a contracted provider, providing early intervention services specifically targeting older Hmong adults. So one of the things, if you look at in the BHSA early intervention section, is like priority populations, older adult, linguistically, non-English speaking linguistic barriers, culturally underserved populations. So the Hmong Helping Hand is a CDEP that actually has clinical components on their team. They've been basically the past couple of years working more as an early intervention, and they're an organization that is set up currently that can claim Medi-Cal, which again, like I said, the requirements that they have, and there's like strongly really focus on doing that. So that's going to change to where they're going to go from where they were an innovation project to an early intervention project with a specific target population. So I'm going to put the discussions screen up, but I'm going to stop sharing for right now, Brian, and just kind of a couple of moments, or you guys can see my green screen. Put something funky back there, Brian. No.
You have to do that.
Yeah. Don't worry about it. We'll go like this, and it looks like I'm going with the green screen. No, one of the things I didn't touch on, and I want to make sure we did, is if you guys remember when I was talking about the slides with the pie charts, and we said that the 30% of the total BHSA funding is for housing, and 35% is for FSPs, and 35% is for behavioral health service and support. Those are for the most part fixed. You can't go like, well, I need this massive need for housing. I need a house, increase my housing to 50%. You cannot do that. The most you can do is move 7% from one category to the other. So if you were saying, I need way more money in housing, and you felt you were not using as much money in your FSP, this is hypothetical, you would then say, okay, I can move up to 7% from my FSP to housing to bring it up to 37%. But you're not going to get to 50 because you cannot move those around. The challenge with if you move it, once you move it and you submit your plan, you are locked in for 3 years. You cannot move that money around. So if you all of a sudden year 2 go, you know what, miscalculated, we found some other revenue source, we found some other way to fund housing. Cool, we don't need it. We want to move this money back to FSPs. You can't. You're stuck with it. So a lot of the counties that we've been talking to are kind of leaving their funding allocation pots the way it is. We're not moving things around. We believe we have enough to cover what we need to. We don't have a ton of money, but we can cover what we need to. And if we move money around, then we risk potentially creating other problems for us over the next couple of years. So Fresno is going to keep their funding allocations current. And I know somebody had asked yesterday about that in one of the forums of like, hey, what about, moving the money? And it's like that you can, but you can only move it a maximum of 7%. And you're locked in once you do. So it's not, you can't adjust it to meet what you may feel would be beneficial. That was one of the things I wanted to make sure we covered with you all. clarification on the FSP ICMs. I'm trying to see if there's anything else. I do need to go back and pull the slide up for you guys in a second, so I'm going to do that. Do we have any questions so far from folks or anything like that? Okay. So this is the opportunity. If you've got questions, comments, you can put in chat. I'm going to give you guys right here because this is probably more useful. If you use, I need that strong. If you guys use that that link, the Fresno BHSA.com, you go to that. It's our MHSA/BHSA page. You will find our surveys on there that are posted on there that you can do. You can share it with people, ask other people to fill it out. You will find information on when the plan is written and we posted. That's the page it's going to be posted on. That's where a public hearing information will be posted on. Anything related to BHSA, MHSA, we post there. We do also try to post those as well on our social media accounts, so on our Facebook or Instagram. But when we post them on those places, we're bringing you this link. So this is the page that you may want to like bookmark to check out. The other thing is you can send comments, feedback, questions, things like that to MHSA@FresnoCountyCA.gov. That goes to a person, Aaron, and some staff monitor. So it's not going to like some empty mailbox. It is tracked. We will try to respond the best we can. Your responses, just know that as we get comments and feedbacks, we do put those in the final plan in terms of part of our community planning process. There are exhibits in there just documenting that people asked questions or provided feedback and that we responded to. I'm trying to think anything else we need to cover for right now. Stop sharing for a second and see if we have anything else in there. How many people do we still have on?
3.
All right. If you happen to have any questions that you come up with later on, or a thought or something like that, like we said, use that MHSA@Fresno. Yes, as far as not as far as the providers and programs.
Read that question.
Oh, yeah. So the question is, have notifications gone out to all providers whose funding will sunset and at the end of the fiscal year? Yes. That was one of the things that delayed us doing our CCPs earlier in the year. I mean, the new year in January, is that because we had made recommendations that we would need to sunset some programs. We needed to make sure that those programs were notified before it came out, because the last thing you want to do is have the news come out in a form where nobody knew. Now, that I don't know if everyone who works in those organizations or served by those organizations, how that has been communicated down, but the leadership of all of those organizations had been notified. And once they were notified and made aware, we were able to then start planning our community planning process, because again, it just would not be, that's not the way people should hear that information for the first time. So hopefully that answers that question. I'm trying to think if there's anything else we haven't covered on this one here. Again, we're going to leave the survey open for another 2 weeks to like middle of February. So 15th, 16th, somewhere in there. So you can totally use that to provide some input as well, or you can still give comments through, the email. And we hope to have a plan soon. If you're on our list, or if you email us also at that MHSA@FresnoCountyCA.gov, we will put you on our BHSA listserv. So anytime there's a community forum, a notice, anything like that, you will receive email for that. So no worries. So we really encourage people to get on that listserv, because that's a better way to do it than hoping you remember to check the webpage for an update, or like if you're not on your social media that often, or how their algorithms don't put us at the top of your screen and you miss out. So the email is a great way to make sure you stay informed on that. But questions come up afterwards, please email us. Let us know if we can help you guys out. Be looking forward to connecting with you all, and potentially we might do like a hybrid live stream in person, I think, public hearing for the 30-day, and then we will get these finalized. And for all of our providers that are working and all those folks in our system of care, thank you for being patient because it's a scramble for everybody up and down the state. And for all of them, it's kind of like, I don't know the answer to this. Like, I don't either, but we will get it the best we can. So really appreciate everyone's patience and working together. And we will try to get this plan out to you guys to review here soon. All right. Thank you, guys.